Good morning to you all. I'll be presenting the ocular manifestations of measles, basically covering four cases of young serving soldiers. Ma'am, can I shift to that side? I am not able to see on this.
Please do.
Thank you. Sorry for the interruption. It's just for the history part of it. The measles, of course, of a zoonotic origin. It evolved from the rinderpest virus that infected the cattle, and actually the human infections were first in the 4th century and generally after 500 AD. The first systematic description of this was given by the Persian physician Muhammadin Zakaria el-Razi, and he gave a book on smallpox and measles, and a distinct identity as 1100 and 1200 AD. So coming to the case history, there were 4 cases. They were 22 to 28 years old males. They presented with history of fever, cough and cold with 3 days duration, multiple rashes, but the more prominent symptoms were the blurring of vision with redness, watering and photophobia. Ocular examination had revealed a visual acuity of 6/24 in both the eyes, and there was conjunctival congestion. There were multiple superficial punctate corneal epithelial and the subepithelial lesions which turned fluorescent stain positive. Fundus was essentially normal. The IOP was 15 and 16. Management, of course, we had to send for the PCA for measles virus, not the typical, because the initial symptoms were first for the ocular manifestations. Treatment was generally on the lines of symptomatic, the fluids, analgesics. We started them on topical fluoromethanol, moxiflux and lubricants. Day 3, the SPKs had reduced in number, and day 7, the visual acuity had improved to 6/6 with clear corneas. Coming to the epidemiology, generally in developing countries, it affects about 30 million children a year and 1 million deaths annually. A single leading cause of blindness, and there is a close synergism between measles and vitamin A deficiency. Coming to the virus per se, it's a single-stranded negative sense RNA virus belonging to the morbillivirus family. That's a Paramyxoviridae. Highly contagious, and it's airborne and with the aerosols through the upper respiratory tract or the conjunctiva. The classical 3 triad, the cough, conjunctivitis and coryza with a maculopapular rash, 3 stages. Symptoms usually develop 10 to 12 days after exposure to infected person and last about 7 to 10 days. The diagrammatic representation, of course, shows the various manifestation, the initial presentation. Ocular involvement, it can be a congenital infection or it can be an acquired. Hallmark is conjunctivitis, and there is, of course, fever and running nose. Corneal involvement, superficial punctate erosions and keratitis, and it can lead in severe cases to scarring or perforation. The more vision threatening can be when the retina gets involved with the optic neuritis, the hemorrhages and the pigment epithelial abnormalities, finally leading to blindness. Synergism, of course, between measles and vitamin A deficiency, xerophthalmia, which has multiple manifestations starting from corneal ulceration, keratomalacia and subsequent corneal scarring and phthisis. So we basically recommend the high dose oral vitamin A supplementation. Severe cases with children, the WHO recommends about 50,000 international units for infants less than 6 months of age, and up to 11 months about 1 lakh, and then of course 1 year and older 2 lakhs. This was basically just to highlight the cases which came in about young patients in this. Luckily, in all these patients, there were no major ocular complications which led to visual impairment and long-lasting visual disability. But of course, the ocular manifestations can be very severe in unvaccinated children, pregnant ladies. However, there is no specific antiviral therapy per se. It's more of a symptomatic, and as far the prevention goes, it's vaccination for limiting the spread. These are the various references. I'm through with the presentation. Thank you.
Any of our judges wants to comment or ask any question?
These people were all vaccinated beforehand?
Ma'am, they were vaccinated beforehand. Ma'am, these were actually serving soldiers, incidentally in the same barrack. So, but in fact, the case series like this has just been published once, which had 9 cases together. So I've actually mentioned it in the references as well. And as far as in our military setup, we are the first time that there were 4 together incidents taking place.
So if they get an incident like this,
Ma'am.
how long would you recommend, suppose these people were not vaccinated,
Ma'am.
then what is the time frame you will recommend to wait before they get vaccinated? Because this would have provoked the immunity.
Ma'am.
So is there a time frame that is required before
Ma'am,
you
there is
recommend
no
vaccination?
per se time frame specifically mentioned, but generally after 6 months of resolution of symptoms, you can vaccinate these individuals.
Did you have to isolate them from the remaining barrack, and did they have skin changes also?
Ma'am, after the initial eye manifestations, they did develop that typical skin rash and those initial symptoms of fever and all. So we had to, because in a barrack there are about 20 people who are staying together as independent, so we had to place them in a different barrack. And of course, we observed them for follow-up even after the symptoms had resolved, the treatment was done.
PCR positivity was from which sample?
Uh,
Ocular sample or the vesicle?
Ma'am, both on the vesicle and well as the ocular sample, both. We took
Ocular
both.
sample also you sent for PCR?
Yes, ma'am.
Did we do the vitamin A levels?
Sir, vitamin A levels at that place were not done. We had to send the samples, but vitamin A samples, the vitamin A levels I have not mentioned in this because I could not gather those.
But did you give them vitamin A?
Ma'am, we gave them vitamin A supplementation, but I have not mentioned the vitamin A levels per se in the case series.
Thank you.
Thank you.
Thank you so much.